I'm Dave Breakenridge, and welcome to Under the Dome. Last week, Alberta introduced new measures in Edmonton, Calgary, and other cities to control the spread of COVID-19. Indoor sports and fitness classes were banned for 2 weeks. Bars and restaurants must stop serving alcohol at 10 and close at 11, also for 2 weeks. Weddings and funerals are limited to 50 people indefinitely. Churches are asked to limit attendance to 1/3 capacity, and people are asked to stop socializing in their own homes. Alberta Premier Jason Kenney said COVID is starting to win. The Premier warned that more strict measures could be in place if people don't follow health guidelines.
And make these sorts of modest sacrifices to social life. The cases will continue to grow to a point where they may grow out of control, and where the only options we have will be far more impactful on people's lives and livelihoods.
Opposition leader Rachel Notley did not call for a lockdown, but she did criticize the government for a lack of contact tracing, as roughly 2/3 of cases are of unknown origin.
Alberta is very close to becoming the most dangerous place in the country when it comes to COVID-19.
On Monday, active cases of COVID-19 went past 10,000 for the first time, and there were 20 deaths reported. It was the deadliest day in Alberta since the pandemic started.
The measures in place right now are literally a matter of life and death, and the choices Albertans are making now will determine our future in a few weeks.
So, are these measures enough, or could more be done? My guests today are Dr. Lynora Saxinger. She's an infectious diseases physician at the University of Alberta. She's also the co-chair of the COVID-19 Scientific Advisory Group to the AHS Emergency Coordination Center. And Danielle Smith, she's the host of the Danielle Smith Show on AM 770 CHQR in Calgary and a contributor to the Calgary Herald. So Lynora, you recently argued in the Calgary Herald that current measures are not enough. What are you proposing instead?
Well, I guess with respect to the current measures, I don't think they're illogical. I just think that they made more sense, I guess, earlier when things were taking off, because they're really targeting where transmission had been occurring over the fall. And now we're in a situation where our contact tracing has been overwhelmed, and we don't really know for sure that the same hotspots are holding true. We also are seeing that our case numbers are continuing to rise every day, and we have not managed to plateau or even start dropping those numbers yet. So my concern was really rooted in the fact that I think our healthcare system is really heading for significant challenges. And the most sure way to try to nip that in the bud and buy us some time to catch up on our contact tracing is to actually have a circuit breaker type lockdown, which is more significant, stricter measures with the, I guess, hopefully more acceptable idea that it would be a short-term and goal-oriented experience rather than a very long experience. So that was what has been done elsewhere, and that's what I was proposing.
Danielle, what do you make of the idea of a lockdown or other further restrictions?
Well, I guess I'm worried about what we mean by lockdown, because different commentators mean different things. I've seen that AFL Gil McGowan, the president, has said that we need to look at what they did in Victoria, Australia. And that was a months-long lockdown, complete lockdown. You had to get permission to leave your house. You got fined if you didn't wear a mask. You got police breaking down people's doors if they tried to organize anti-lockdown protests on the grounds that they were inciting violence. And so I don't think we want to go in that direction. It seems to me that if we've got a system that we spend $20 billion on, that we have 103,000 people working for Alberta Health Services, they should have spent these last 6 months figuring out how to build the surge capacity. That's what I'd been hearing all the way back in March, April. That's what I thought the original closures was all about, was to get our hospital beds up to 2,000 or more, get our ICU beds and the staff for them trained up to over 1,000. And it does seem to me, did we take the foot off the gas? Was it that we didn't anticipate that there would be a fall surge? And if that's the case, then we need to be focusing on where the solution is. And the solution is not telling kids that they're not allowed to see their friends, and it's not ending hockey practices. It's actually building up that surge capacity in the hospitals. And if we don't do that, then all of the lockdowns in the world aren't going to make a difference.
Regarding concerns about capacity, Lynora, as a physician and someone who's been on the COVID-19 advisory group, why are there issues with capacity? Back in the spring, Jason Kenney and Dr. Dina Hinshaw were talking about the ability to open 1,500 ICU beds. And now we're talking about the capacity issues. Where's the disconnect?
I think that there's a central fact that is leading to the disconnect, which is that a bed is more than a bed with the oxygen tube stuck in the wall. And so when people were looking at, the news out of Italy, those terrible images that just emblazoned themselves on people's minds and memories as to what the healthcare system was facing there, we were looking at that and saying, what would happen here? And it was really imagining this catastrophic scenario, and the projections were astronomically high and didn't actually happen because our measures were effective. And during that time, the assumption was that should things be that catastrophic, that basically almost all other activity would shut and all resources would be directed to COVID. Now, during the actual shutdown, the hospital capacity was underutilized for a period of time. It was ready, it was waiting, and the measures actually were so effective that we did not have a surge that was really significant to the degree that was anticipated. We came close to our stage 1 ICU level for a period of time while Calgary was having their kind of overlapping outbreaks, but we never really exceeded capacity. And looking back at that experience, it was clear that it did disrupt care to a great degree, that we think that it actually did push some people's health problems, I guess, into a more urgent space because of delayed care, delayed needed surgery, et cetera. And so there was a commitment that we would try to keep on treating everything else and adjust our need for COVID beds as required. Now, the thing that's kind of thrown a big wrinkle into this is healthcare staffing capacity. You cannot make healthcare workers out of thin air. You cannot clone them. If they have to be quarantined because their kids have been exposed, if they have to be quarantined because they've been exposed, there's just very little surge capacity at the best of time in the fall and winter. We've actually had a number of healthcare workers also leave. And it's actually, I think, kind of an evolving slow motion crisis in terms of the healthcare worker capacity to support the beds. So to me, the concept is not a bed. The concept is an adequately staffed bed. And we've always seen that ICU is actually the bottleneck for that because critical care is highly specialized and you can't just pull people out of anywhere to run that properly.
Now, I want to talk about that in the lens of something the Premier's been talking about, and that's keeping the economy open and letting people exercise their right to earn a living. Danielle, if cases continue to rise and people are more inclined to stay home out of fear or risk, or worse, we have to see further restrictions on businesses anyway, aren't we hurting businesses like restaurants that we're purporting to help?
I think people are really good at assessing their own level of risk. I happen to run a restaurant, so I've been able to monitor this all the way through when we opened in May and then through June, July, August, and September, October. And our sales have been consistent for the last 3 months. And so that says to me that those who have done their own level of assessment about their own level of risk, about the people in their lives that might pose a risk, have a certain level of comfort in going out. And those who have assessed their risk as being higher are staying at home and reducing their social circles. The Premier himself has gone through quite great lengths to explain that less than 1% of traced cases come from restaurants. So I think what I'm worried about, what I'm hearing is that the medical community wants to be seen to be doing something. And so rather than do the right thing, which is for the past 6 months, they should have figured out, do you need to have a dedicated COVID hospital? Do you need to have additional hospital capacity built on with, for instance, the sprung structure that was to be outside the Peter Lougheed Centre? Do you use some of the empty hotel capacity so that you can get your long-term care facilities down to only having one person per room rather than two persons per room? Do you need to have a rule in place that nurses shouldn't be allowed to work in more than one facility? Is that what caused the spread in long-term care? I feel like because they haven't done the work they needed to do in the hospital administration to prepare the hospitals, to prepare the continuing care centers, they're now pointing out at the private sector, saying, you're the ones who are going to have to reduce the spread. I'm far more interested in seeing a focused protection on the most vulnerable in our long-term care facilities. We know it's those over the age of 70, those with one or more pre-existing conditions that are the most susceptible to dying of COVID. And so making sure maybe you have a rule that the kids who are out partying and seeing each other in their 20s, they're not allowed to visit long-term care facilities, or they're not allowed to go to hospitals. Like, it strikes me that we've got to make sure that we're clamping down on the right thing, because as we know, the vast majority of cases are mild cases. There's a lot of cases that are asymptomatic. And so to me, if you want to protect those who are most at risk, you do it by doing it directly, by protecting those most at risk.
Lynora, what about you?
Yeah, just a couple of things. I guess starting with the idea, which I think has been, and it sounds very logical, why don't we just try to protect the most vulnerable? And I guess the problem that I have with that as a thesis is that it actually has not worked anywhere. Like, nowhere has successfully kept the virus out of the long-term care congregate living population. The reasons for that are many, but the main reason is biological, because this is an incredibly stealthy virus. It actually can spread from people who are not symptomatic enough to even recognize that they're sick. And for that reason, it can infiltrate quite widely before you even realize there's a problem. And some people will always get sick. And so the idea that it doesn't matter if it's in the general healthy population, I think is actually very dangerous, because people in their 40s and 50s, and especially in their 60s and over, can get fatally, horribly ill with this and die in front of your eyes in a very short time. So although the number of deaths in the younger population is less, it is not zero. It is still higher than influenza. And as you get older, below above 60, so overall population-wide, if you just let her rip, which is essentially what's happening in the US, the case rates just south of us are approximately 10-fold higher, active case numbers. They have completely overwhelmed their healthcare system. And there are, really a very large number of excess deaths, when in fact, we know that in some months, probably around 4 to 6 months, we should have a vaccine available that will protect people. And so during that time period, how many extra deaths are we willing to accept, especially given the good news on the vaccine front? And so I think that the idea that we can protect the vulnerable has been proven wrong so many times. And actually, I also took a bit of exception to the idea that nothing was done in the intervening time period, but not everything is public. There have been assessments of field hospitals, assessment units. There's been assessments of hub and spoke models. There's been a lot of things, but the one thing we cannot do is create more healthcare workers, especially when we're losing healthcare workers to elsewhere. And so there's this hard stop in terms of the capacity that is really mostly personnel based. And the planning that's gone on, I think, has actually been very good. But like I said, it's not necessarily always in the public eye. And then the final thing I was going to comment on was that the transmission in community right now is too high. For the kind of later part of the summer and early fall, we were running about 100 to 150 cases a day. Our healthcare system could manage that, and there was relatively decent kind of freedoms for people to do things that they wanted to do. The tipping point probably has to do with the seasonality of the virus, because the biology actually does change. It is more transmissible in drier, colder climates, and also it's driven us all inside. And so that combination has tipped us up to this point of really still continued exponential growth. And I don't think, can finesse our way out of this by elegant, targeted interventions. I think we have to basically smack it down and then try to design the elegant, targeted interventions to get us through to the spring and early to mid part of next year. Because we really are in a state right now that is very challenging. And I don't want to downplay that. I think it's a very big deal.
I don't think we want to downplay the consequences of lockdown, the consequences of job loss. And Dr. Ari Jaffe at the Stollery has done an assessment on this. He thinks that there's the potential to have 10 to 50 times the number of deaths associated with the failure to treat heart disease. We're seeing a high level of heart attacks going untreated, dying in the homes in other jurisdictions, failure to diagnose and treat cancer, the domestic and child abuse increases that we're seeing, the suicides, the deaths of despair associated with drug and alcohol addiction. Like, if all you want to focus in is on one aspect of healthcare, then it would be, as the Premier said, a very easy decision. You could lock down, as they have in Australia, for 3 months. You could lock down, as they're proposing in Germany, for 4 or 5 months. But you have to, I think, take a holistic view. I think those deaths also matter. It does strike me, and keep in mind, I do a radio show with people who have those frontline hourly jobs who just don't have the luxury of being able to work from home and get full pay. They absolutely, I think they don't want somebody deciding whether or not their job has value, whether or not they should be allowed to work or not. People who run retail shops don't like the fact that Walmart is able to stay open because they happen to have a food section, even though their retail shop can't. And these are some of the inequities that we end up getting if we have academics deciding who has a right to work and who does not have a right to work. I think that we need to look around the world and be realistic that you can say that a focused protection approach hasn't been successful, but I would argue that trying to stop viruses with lockdowns hasn't been successful either. We have, whether you have a lockdown or not, whether you have focused protection or not, we continue to see this virus spread. No one's been able to stamp it out. So unless you believe China's numbers, and I must tell you, I don't think China's necessarily the model that we should be following. The World Health Organization, up until this pandemic, has said the same thing. They said you don't isolate and quarantine healthy people. And instead of following the World Health Organization, who did peer-reviewed studies on this, I just read their pandemic planning document from a year ago, we decided to take the China approach. So I'm of the view we should go back to the science. We should go back to what the World Health Organization has said, which is not to do lockdowns. And then we should try to find a way of increasing capacity and focusing on those efforts or those activities that might have the most risk rather than trying to take a shotgun approach.
Dr. Saxinger, if you want to respond, then we'll wrap it up.
One thing that I have to point out, just as a basic starting point, is that hospital capacity is not going to protect people from dying. We do not have highly effective therapy for this. And so it's supportive care and hope for the best, and give some steroids can reduce the likelihood of mortality. There's no antiviral that has been proven to reduce mortality. And so letting it go through the population and saying all we need is hospital capacity and ICU capacity and it'll be fine is actually actively misleading. Because if you look at, for example, Stockholm, where they had restrictions in place that were voluntary, and actually I think the population did really change what they were doing during the height of their epidemic because they saw what was going on. They had it would be the equivalent of 8,500 extra deaths in the Calgary Edmonton corridor in Alberta during their first wave. So that is what this looks like if you just let it go. So I think that that is a number that would be unacceptable. And I think that the controls are required to prevent that, whether we have hospital beds or not, because people can also die at home. So I actually think that the current discussions in a way seem quite skewed to me, away from the biologic realities of what this infection can be like. Many people have inapparent nuisance symptoms, but many young people also, and people in their 50s and 60s and 70s, as well as those in their 80s through hundreds, can get sick and die with this. And in fact, the pandemic itself has very severe economic consequences. There's a good evidence base around this that I think is showing us that, an uncontrolled pandemic is actually potentially almost as bad as a lockdown in terms of what it does to businesses, but without actually the benefit of decreasing deaths. And so that's my bottom line. I have no interest in trying to ruin anyone's livelihoods. I actually think that the other problem is we're talking about lockdowns like they would go on forever. I'm really talking about a target lockdown to bring the numbers down to a place where we can manage it better, where we don't have to make tough choices in healthcare, because the tough choices in healthcare will disadvantage people who are not actually in major centers. And I think it's profoundly important that we protect our capacity to care for all of the other things and not have an extended lockdown. And at the moment, the worse it gets, the longer and harder the lockdown would have to be to prevent excess deaths in the community that I think people really would not find acceptable. So I'm just coming back to the biology and the medicine. And I think that it's important to recognize the effect on livelihoods as well. I think that we can actually do both.
Danielle Smith, Dr. Lynora Saxinger, thanks very much for your time. Thanks for coming on. That's it for this episode. Don't forget to hit the subscribe button. And you can also find past episodes at edmontonjournal.com/underthedome. I'm Dave Breakenridge. We'll see you next time.